Today's lecture is divided into 4 parts, gallbladder and bile ducts. Part 1 will talk about the anatomy, physiology, including bilirubin metabolism and imaging. In part 2, we'll talk about gallstone and the related diseases of the gallbladder. In part 3, we'll talk about the other diseases of the gallbladder, including bile duct strictures, gallbladder polyps, and malignancy. And in part 4, we'll briefly go into cholecystectomy, its indications, surgery, proper, and complications. Okay, now we look at the surgical anatomy of the biliary system. The biliary system consists of 2 parts. One is the gallbladder and the other one is the bile ducts. The gallbladder consists of the fundus, body, neck, and the Hartmann's pouch, and finally the cystic duct. Whereas the bile ducts consist of the right and left hepatic ducts, the common hepatic duct, and the CBD. And these two systems are connected by the cystic duct, as shown in this diagram here. Okay, this is the gallbladder, fundus, body, Hartmann's pouch, and the neck. And this is the cystic duct, which connects the gallbladder to the biliary ducts, which consists of a right and left hepatic ducts joining to form the common hepatic duct, which in turn joins by the cystic duct to form the common bile duct. And this common bile duct goes downwards and to the right to enter into the second part of the duodenum. The surface anatomy of the gallbladder is very important. When you examine the patient, it is very important to localize the exact site of the gallbladder. Now, what are the landmarks that can be used to locate the gallbladder? First is it is located at the right upper chondrium, as indicated by this ring number 1. Next, you have the transpyloric plane, number 2 here, which is a horizontal plane at the level of the lower border of L1 vertebral body. Then the third is your midclavicular line, number 3 here, a vertical line from the midline of the clavicle. Okay. And fourthly, the angle between the right costal margin and the lateral border of the rectus abdominis. Normally, it is not palpable, but if the gallbladder is palpable, it is abnormal. Now we come to Kellogg's triangle. Okay, the Kellogg's triangle is this gray shaded area here in the region of the gallbladder and the bile ducts. Its boundaries are lateral border, the cystic duct, and the gallbladder. The medial border, the common hepatic duct, and is branched the right hepatic duct. And the superior border is your lower surface or inferior surface of your right lobe of your liver. It is important to know the contents of the hepatic Kellogg's triangle, which consists of the right hepatic artery and its branch, the cystic artery, which supplies the gallbladder. It's also a lymph node which is located in the center of this triangle, and this is known as the cystic lymph node of Lund, which drains the gallbladder. It's the primary lymph node that drains the gallbladder. This is the anatomy of the gallbladder, CBD or common bile duct. Okay, it's divided into 4 parts. It's about 7.5 centimeters long and about 6 millimeters in diameter. So this is a very important figure, 6 millimeters. Anything more than that is considered dilated. It consists of 4 parts. Okay, the first part is known as the supraduodenal part here, above the duodenum, where it is formed. Okay, it's about 2.5 centimeters long. Second part is the retroduodenal part, behind the first part of the duodenum. The third part is the infraduodenal part, okay, infraduodenal or transpancreatic part on the posterior surface of the head of the pancreas. And the fourth one is the intraduodenal part, the part that enters through the wall of the second part of the duodenum. It opens the second part of the duodenum as the ampulla of water. Okay. and ends on the summit of the summit known as the papilla, which is identified on endoscopy. Okay, now close-up view of the ampulla of water and the sphincter of OD. This is the fourth part of the CBD, which is formed by ampulla of water is formed by the common bile duct and the pancreatic duct within the wall of the second part of the duodenum. It ends at the sphincter of OD, and this is a circular muscle that covers the tip of the ampulla of water, which controls the flow of bile and pancreatic juice into the duodenum. Okay, it's a muscular valve. It's a very important structure, especially in ERCP and sphincterotomy, where the sphincter of OD is to be identified as the papilla. Okay. Okay, now we come to the physiology of the gallbladder and the bile ducts. Okay, at the liver, the bile is produced, and the production of bile, the bile constitutes 97% of water, 1 to 2% bile salts, 1% bile pigments, cholesterol, calcium, and fatty acids. It is excreted at around 40 mL per hour, which works out to be around 1 liter in 24 hours. Okay. At the gallbladder, three main functions take place. Okay, the gallbladder acts as a reservoir for bile, storage of bile during fasting when the bile is not required. The concentration of bile is another function of the gallbladder. It concentrates the bile to as high as 5 to 10 times by active reabsorption of the water. And it also produces mucin at around 20 mL per hour to lubricate the gallbladder. And as far as the neuroendocrine control is concerned, it is dependent on the vagus and cholecystokinin or CCK. Okay, so when the food enters into the duodenum, the vagus and cholecystokinin help to contract the gallbladder and the sphincter of OD to relax at the same time. Okay, and this synchronization of gallbladder contraction and relaxation of the sphincter of OD results in the excretion of into the duodenum. Okay, in this slide, we look at the bilirubin metabolism in normal individuals. Okay, in this chemical pathway, there are three main phases: the prehepatic phase, the intrahepatic phase, and the posthepatic phase. In the prehepatic phase, which takes place in the circulation, the RBCs are destroyed in the spleen mainly, and this produces unconjugated bilirubin. And this unconjugated bilirubin is non-water soluble. It is absorbed into the hepatocytes in the liver in the intrahepatic phase, where the unconjugated bilirubin is conjugated to glucuronic acid, and that results in conjugated bilirubin, or CB as mentioned here. Conjugated bilirubin is then secreted into the bile ducts, and these bile ducts carry the conjugated bilirubin into the small intestine, where the bacteria act on it and convert it to urobilinogen and stercobilinogen. Stercobilinogen is excreted in the feces, which gives the normal brown color to stools. A small amount, 10% of this urobilinogen, enters into the enterohepatic circulation between the small intestine and the liver through the portal circulation. And some of this little urobilinogen diffuses back into the circulation and is excreted by the kidneys as urobilinogen in the urine. And usually this is found in trace amounts in the urine. So in summary, you have the prehepatic blood where there's unconjugated bilirubin. Then in the intrahepatic phase in the liver, it is conjugated bilirubin is formed. And this conjugated bilirubin in the posthepatic phase in the bile ducts is carried in the bile ducts into the intestine where urobilinogen, circobilinogen, and the enterohepatic circulation are encountered. Imaging of the gallbladder and bile duct. The most useful initial investigations include plain X-ray of the abdomen and chest. And more important is the ultrasonography or ultrasound of the abdomen. Together, these two are the most useful initial investigation for all gallbladder and bile duct problems. Others include computerized tomogram, CT scan for mass lesions, magnetic resonance cholangiopancreatography or MRCP for imaging the pancreatic and bile ducts, endoscopic retrograde cholangiopancreatogram or ERCP, and endoscopic ultrasound or EUS with biopsy. The other lesser investigations will be listed here. Among them, still in use is a percutaneous transhepatic cholangiogram (PTC), preoperative cholangiogram X-rays (OTC), radioisotope scan or the HIDA scan, which refers to hepatobiliary immunodiacetic acid scan. And of recent importance, becoming important nowadays, is your indocyanine green fluorescent scan, ICG. Okay, what is the use of plain X-ray in bile duct and gallbladder disease? First, only 10% of gallstones are radio-opaque. Okay, this is an important fact that must be understood. And this is a plain X-ray of the abdomen showing a gallbladder filled with radio-opaque stones. Secondly, some gallbladders may be totally calcified, and these are known as porcelain gallbladders. Okay, here you see the gallbladder, the whole wall is calcified, and this is known as porcelain gallbladder, which is believed to be a pre-malignant condition for carcinoma of the gallbladder. And thirdly, gas in the bile ducts, also known as aerobilia. Okay, this is usually due to infection of the bile ducts, especially these days with the widespread use of ERCP. Infection may be an important complication. Okay, here is a X-ray showing you aerobilia, air in the biliary tract. As I said, these days most commonly manipulation, ERCP, and the manipulation of the bile ducts is a common cause of this aerobilia. Okay, so you have gallstones, porcelain gallbladder, and aerobilia, all diagnosed on plain X-ray abdomen. A bit more on ultrasonography or ultrasound scan. Most important initial imaging for gallbladder and bile duct. It is safe, painless, accurate, convenient, cost-effective, readily available, and no radiation involved. It is capable of detecting gallstones, gallbladder, its thickness of the gallbladder wall and surrounding inflammation. It can detect the size of the bile ducts. The normal maximum diameter of the common bile duct is 6 to 8 millimeters. Sometimes stones in the common bile duct and growth in the pancreas can also be detected by ultrasound. Okay, this image, ultrasound image here, shows you a normal gallbladder here, okay, filled with bile, which is hypoechogenic. This is the neck, body, and fundus of the gallbladder. Okay, the lumen is clear, there's no stones. This ultrasound image shows you another picture of a gallbladder here with multiple hyperechogenic shadows, lesions within the lumen, which are gallstones. And how you know it's gallstones? Because they cast posterior shadow on the ultrasound. The wall of also thickened, wall of the gallbladder is thickened, and possibly there are some perischolecystic fluid as well. These are features of acute cholecystitis.
or by means of the assistant. Next we'll talk about an important part of the operation, which is dissection of Callow's triangle. Here we can see the gallbladder being retracted anteriorly and superiorly, and subsequently there is blunt dissection of the area of interest around the cystic duct and cystic artery where the peritoneum is overlying this. Note that diathermy isn't used in this area as it is very close to important structures such as the common bile duct, which is susceptible to thermal injury. As you can see, the peritoneum is peeling nicely away, and often these instruments can be used to make windows in the posterior plane. As you can see, opening up the instrument allows for nice blunt dissection in those anatomical planes. Here we can see window being made more posteriorly. Another common method aiding the dissection is using the suction irrigation device. This allows for nice gentle dissection, as you can see here, just gently peeling away some of the overlying tissue, peritoneum and fat. This allows you to obviously simultaneously use the suction on the bleeding and also irrigate as required. Here we can see a good example of how a blunt instrument is being used to safely open up a window behind the cystic duct. Certainly as a medical student, when faced with a view such as this, it can be really difficult to decide what's what in terms of anatomy. Therefore, with the aid of an overlay diagram, we can see superiorly the gallbladder, we can see the cystic artery and the cystic duct coming down to join the common bile duct, and finally the duodenum. Here we can see where we'd like to ligate the cystic duct and cystic artery. I think it's important to note how close these two structures are to other important structures such as the common bile duct and the duodenum. Next we'll see identification and ligation of the cystic duct and artery. Here you can see, now that it's been identified, the cystic artery is being clipped. 3 clips will be applied, and subsequently a cut will be made distal to the second clip, meaning that the stump of cystic artery left behind has 2 clips applied. There's the 3rd clip being placed nice and close to the gallbladder, and subsequently being cut using a laparoscopic scissors. The cystic duct is clipped much in the same way as the cystic artery, and here you can see the first clip being applied to the cystic duct. Next we'll see resection and removal of the gallbladder. Now that the cystic duct and cystic artery have been ligated and transected, dissection of the gallbladder can begin, and here you can see a hook diathermy being used and the appearance of the loose areolar tissue, which is the anatomical plane for dissection. And the hook diathermy is very frequently used in this part of the operation as you're working your way away from the important structures, and also you can often encounter quite a lot of bleeding in the gallbladder bed as it's very close to the liver parenchyma. Here we can see how the hook diathermy is being used in the dissection of the gallbladder away from the gallbladder bed, using the heel of the diathermy and adequate retraction laterally of the gallbladder, and then easing its way off. Here you can see the gallbladder has been fully dissected off the liver, and you can see a Burt bag just on top of the liver and the gallbladder being delivered into the Burt bag, where it can safely stay on top of the liver while a final inspection for bleeding in the gallbladder bed takes place. Here we can see suction irrigation being used to make a final inspection of the gallbladder bed, just to check from any bleeding from that liver parenchyma. As you can see here, it looks nice and dry without any further bleeding. Finally, we'll talk about closure. Now, in terms of closure, the 10mm port sites should be closed with a deep and superficial layer. This would prevent any future formation of an incisional hernia. The 5mm ports are often closed with subcuticular sutures or wound glue. Finally, we'll talk about the complications of laparoscopic cholecystectomy. Bleeding may occur from the cystic artery stump itself or the liver parenchyma in the liver bed. Infection, this might be surgical site infection or intra-abdominal infection. A bile leak might occur from the cystic duct stump or directly from the gallbladder bed itself. There may be inadvertent damage to the common bile duct, and this may require extensive surgical reconstruction. Damage to other structures, this may occur during the operation or during the laparoscopic port insertion. It's important to mention the risk of the anaesthetic and VTE, or venous thromboembolism, to those patients with significant comorbidities, and finally the risk of conversion to an open procedure or indeed failure of the procedure. So just to go over what we talked about today, we discussed the indications for a lap chole, we went over the basic anatomy important in the procedure, the surgical steps were covered in a chronological order, and finally we talked about the complications. Thank you for listening to a video podcast by School of Surgery. Remember, you can follow us by searching School of Surgery in Facebook. You can subscribe via iTunes. Go directly to the website schoolofsurgery.podomatic.com, and we'd like to say a final thank you to Stores who made the video footage available. Thank you very much.
Okay, thank you for joining me for this lecture. Thank you for your patience, and I hope to see you again in another lecture. Thank you.